Hello and good day to you. It's a pleasure to be here again. And it's my pleasure also to introduce Professor Tatjana Milenkovic. So she's a dear friend of mine. She's the president of the Diabetes Education Study Group. She comes from North Macedonia in Skopje. She works also at university at local hospital also. And so, Professor Tatjana, you had a big challenge now because obesity is in the focus of our attention. And we will look forward to know a little bit more about the new treatment for obesity in pipeline. So what do we have in the future?
Thank you. Thank you so much for your kind invitation. And also thanks to the organizing committee of ASD and special to Professor Inas for this kind invitation to be here again with you. I'm really enjoying always because of your kindness and hospitality, so it's a great country to visit and to stay a bit more here. So today my task is to speak about what are the new treatments for obesity in pipeline. And at the beginning, I thought that it will be the easy task, but I realized that it isn't because there are so many things that I would like to share with you. But I will stick on something that is really, it will be very soon available for us to share or to prescribe to our patients. So when we are speaking about obesity in general, it becomes more and more global problem. And in this moment, there is people with obesity near to 1 billion worldwide. So more than half of the world population is either overweight or obese. And this problem, or obesity, has nearly tripled since 1972. And what is for me, even biggest problem, that there is increasing in obesity in childhood, and that is the population that for sure will have the problem with this in their later life. So this is from the newest atlas released last year. So what is the situation with obesity in your country in comparison to my country? Because we do have also a very big problem with obesity, and as it is here in Egypt. And here, as you can see, that there is the 49% of population with obesity, and especially in female population in your country. And what is also a very big problem is that there is a higher incidence in obesity in childhood, which will be the problem in very near future. So really, as a countries, we do have a very big problem with obesity that we should address very soon, if it is not too late, because these are potential candidates for many diseases, not just diabetes, because why is it is the importance of obesity? Because it is followed with many complications like mental, metabolic, mechanical, and also there is a shortened life expectancy for those with obesity. So the chances for people with BMI from 35 to 40 to reach 70 years of age is 60%. And with those with morbid obesity, just 50%, so that it's clearly said that their life expectancy is very shortened with obesity. These are our recommendations. How should we treat persons with obesity? And of course, we should first start with diet, physical activity, behavioral treatment, which is the cornerstone for this. And I think so that without this, we won't be successful with any further treatment that we have in our hand. So it is important to teach these people or to give them support how they will lose weight. Then, since 27, BMI and higher, you can suggest pharmacotreatment in those with high risk, and also for those above 30 BMI, we can suggest even metabolic surgery, of course, with those with a higher risk. So what is our new recommendations in diabetes care from the beginning of this year? It became very clear that any magnitude of weight loss is important. But if the patient is able to lose 3 to 7% of his basal weight, then it's good, and even better if he loses more than 10% of initial body weight, because this loss of weight can modify disease and also can possibly lead to remission of type 2 diabetes and also improvement of all complications related to obesity, especially cardiovascular complications. So I'm showing at this slide what are until now, what is the drugs that are approved by FDA for obesity treatment, and we know the potential of each of these medications. So I will try to answer, is there is something in pipeline that is even better than we have until now. So the best, regarding the potential of losing weight is semaglutide and tirzepatide. These are weekly injections that are able to make a significant reduction of body weight up to even 20%. So these new drugs are all based on this multi-receptor agonism, because there are a couple of these GLP, glucagon, amylin, also this small peptides from intestinum, and mixing of these all drugs affects different pathways of obesity. So it is better result when we are combining all these drugs together. So what is in the pipeline? Very shortly, what is coming, this is in phase 3. This is oral semaglutide in a dose of 50 milligrams per day, which can reduce the initial body weight up to 17%. And also it is important in these trials that the people who were able to reduce even 20% of initial body weight was 1/3 on those that were included in the trials, which is a very good result. It's also important for oral semaglutide that the people that were involved in this trial from last year published in Lancet, the people was with normal glycemia or with pre-diabetes, and at the end of the study, that was a turn in this green and yellow column, that there was also 75% of those on this drug that they regain a normal HbA1c below 5.7. So this is also promising for those in prediabetes who is obese, with losing weight to prevent further development of diabetes. That's also, it's in third phase, orforglipron. This is oral, non-peptide small molecule of GLP-1 receptor agonist, and also it makes a significant reduction in body weight in different doses, and in maximal doses of 36 and 45 milligrams, the reduction is near to 15-16% of initial body weight. Also, one of the drugs is survodutide. It is a glucagon and GLP-1 receptor agonist mixed drug. Then also can reduce the relative body weight, as you can see, up to 15% after 46 weeks of this trial. So this is the significant body weight of 15% that can also make a metabolic improvement in those patients. So now the survodutide is in third phase of its program, and this is a synchronized program that is going even further and is not the subject of the trials just percentage of body weight that the patients can lose, but also it was studied, these two trials, these are the third phase studies with obesity and overweight without and with diabetes. And the third the third trial is about CVOT trial for those with established cardiovascular diseases and at high risk for it, how this drug will be beneficial for this category of patients. And also it was shown for this drug, it also published this work this year, that it is very good in MASH and it's metabolic not fatty liver disease, not alcoholic fatty liver disease. It was shown that it can reduce significantly the enzymes IS10 and ALT for even 38 units per liter, which is very, very good results for both enzymes in people with MASH. So now the studies are going even further to see how these drugs are doing related to some other complications that are going together with obesity. One of the biggest potential is in this drug, retatrutide, which is a triple agonist, GIP, GLP-1, and glucagon receptor agonist. And with this drug, there was a significant reduction in body weight, almost more than 20%, 25%. And in female, and those who are with BMI over 35, then the body weight is near to 29% of initial body weight, which is a really very big weight reduction. Also, this drug was examined in MASH, and these results for me are even more important because in this graph you can see what is the relative liver fat reduction, which goes up to 86% with a higher dose of retatrutide, 12 milligrams. And this also, it shows that even in 93% of patients, it was a reduction in fatty liver content less than 5%, which is really good result for those who are affected with this problem. The third phase of retatrutide is also not just for obesity, MASH, but also for obstructive sleep apnea and knee osteoarthritis in people with obesity and overweight. And also there is an ongoing trial for patients with high BMI, with second and third class, and established cardiovascular disease to see how is the cardiovascular protection of this drug in people with obesity, with or without diabetes. Also, this is the drug in the third phase, cagrisema. It is a combination of cagrilintide with semaglutide in same dose. They are co-administered once weekly. And here you can see that it is a good weight reduction up to 15.6% and average increase in time in range about 43% in these people which are examined in this trial. Also very new data from from last year. Mazdutide, it is also agonist of GLP-1 and human glucagon receptor, GCGR, with very good also results in body weight reduction. And here you can see in these graphs, it is at 2 doses, but it is reduction in body weight up to 16% of initial body weight, and also change in waist circumference, which means that they're losing the central obesity, which is important as a cardiovascular risk factor. And what is the final, this was to announce that the EASD meeting in Madrid this year in September. It is a new formulation, or amycretin. It is oral amylin and GLP-1 receptor coagonist, and this is the first human trial. The results were shown so recently. The first results are concerning the safety. That is quite safe. There is only mild and moderate gastrointestinal news effects like for many of these drugs, but also with a good potential to for patients to lose weight in one dose of 50 milligrams or 100 milligrams, so it's up to 13% of initial body weight. So this is just the beginning of examination regarding this drugs. So there are so many other drugs in pipeline for obesity treatment, but this is maybe with the most potential: tirzepatide, cagrisema, retatrutide. This is the drugs that are coming in the next years. They are almost in the final phase. But I'm showing this just to see how many of them are coming. These are drugs that we are talking about in the third phase of obesity trials, and there are even more in a second phase of obesity trials. So many drugs, and of course that the future will tell not just about their efficacy, about their safety, and how they will be beneficial in our efforts to stop this pandemic development of obesity worldwide. So, if I can conclude that, that treating obesity actually is very important, because with that we can prevent not just diabetes, but complication, especially cardiovascular or cardiometabolic disease. There is a lot of innovative incretin treatments that are under development. We will see what future will tell about all of them. I suppose that it will be very expensive, that there will be expensive drugs which we should suggest for our patients to take them a long period of time, because after stopping, the problem will return. So we have to find a balance between these other approaches to treat obesity, not just medicamentos treatment, but the potential of new drugs are becoming very similar to those of metabolic surgery, so maybe it will be some development in this relation. And of course, the treatment of obesity and access and affordability of these all therapies, it will be our priority in the next period to be more efficient in the treatment of this quite serious disease. So thank you for your attention.
Thank you very much. Please join us.